social work.
Okay. Yeah, please go ahead again.
So yeah, my name is Ashna Goyal and I'm pursuing Masters in Social Work from Delhi School of Social Work.
Okay, welcome Ashna. I think we have two people here in the room who have joined after the first session. Yeah, can we hear? Just introduce yourself.
Hello, good afternoon.
Oh, okay. Yeah.
Myself, Dr. Ruqayya Fatima. I'm a pediatric occupational therapist. I'm running my own clinic in Sukhdev Vihar. Am I audible?
No, I could hear you, but not very clearly. Maybe you're too close to the mic.
Myself, Dr. Ruqayya Fatima. I'm a pediatric occupational therapist.
Okay, now I got it. Yeah.
I'm clinic in Sukhdev Vihar.
Okay, great. Thanks.
Thank you so much.
Dr. Fatima, yeah. Let's see. Anybody else online? No. What? There were just 4. Yeah, I know. 2 of them. Yeah, who haven't introduced. नहीं ये and यहाँ. Yeah, please.
Hello, myself Pawan Arora from Examination Office.
Okay. What about you? I mean, you haven't introduced yourself to everybody, so.
My name is Jerome Cable, master student at JGU at specifically in the area of international relations. I'm glad to be part of this conversation.
Also from Liberia. Yeah.
Also from Liberia to conclude. Thank you so much.
Yeah. Okay, let's go on to the second part. Can you just switch on the next PPT to guide me and also to keep people who are online to engage them? Yeah, after having the first session, people who missed it, I mean, we were just trying to unravel, and come to a common understanding of health. And we dealt with about, a spectrum of health, where from death to illness to mild illness to this thing. So we showed a gradation, and then people were encouraged to give some kind of a ranking to different, that how we perceive health and what the average person on the screen. We put some different some people, whom we had described, and we were asking whether, they would have good health, or who would have the best health and who would not have the best health. And then we saw a video on public health, or what comprises public health. And basically, it's a video about showing how anything that deals with preventing death and disability, and disease, all these are public health. And so, from ambulances to police vans to air quality and food quality and water quality, all that was being shown there, including prevention of accidents. So it just opens the realm of public health, because the idea of public health also is that the determinants of health are not typically left to the health and family welfare department, but public health is achieved by a whole lot of other departments. And yes, society in general, villages, communities, families, all contribute to public health. But anything which is not in the private hands of a person to improve his or her health, normally we say that it comes into the domain of public health. So I'll just move from here. So I'll just show this. Can you see this? This is about 4 states of India. And infant mortality rate, it's showing the infant mortality rate. This is from the latest NFHS 5.
Sorry.
Can you all see the screen?
No. We can't see the PPT. So if you could share it again.
Yeah, we'll just check that. Thanks for informing us. It's been a challenge since morning. Can you see it now?
Yes.
Oh,
yes.
Great.
Yes, it's great. We can see. Yes.
Thanks for informing us.
You click on the hide thing. down.
Is that okay now? Can you see the screen now?
Yes.
Yeah.
Yes.
So this data is from the last NFHS 5, which has been published. NFHS 6 has also happened, but the government has not released the data for last 2 years. But this is a figure of this thing just for everyone to get on the same line. Infant mortality rate is considered to be the most comprehensive indicator of health. If you have to compare two places or two communities, we normally go by the infant mortality rate. And this normally means that an infant in medical terms is anybody less than the age of 1, person who's not completed his first birthday, his or her. That's what we call it. So people who die before the age of 1. And when I entered my immediately after my medicine, when I was in the field, India's infant mortality rate at that time was about 150 per 1,000 live births. That means 15% of all children who were born alive died before the age of. And here it is, the rural and urban divide has been shown between different states. Madhya Pradesh, you can see the rural urban. Kerala, Bihar, Meghalaya. So I'll just request all of you to just digest it, and if you have any comments, please come up with it. One comment per person. Yeah. Anybody online also, so that we know that you all are with us. What do you see there? What do you observe?
It's just we can see the rural and urban divide, say like from Madhya Pradesh, Bihar, Meghalaya. Like it's like the strange thing is like Kerala, where we can see mortality rate is less in rural compared to the urban. So yeah.
Okay, we'll come to it later. Let's hear about why do you think the divide is there in the others? A very stark divide between.
So there are various reasons, like so social reasons, economic reasons. So there's a different reasons. If, for example, in if we talk about rural areas particularly, so then it's infrastructure, roads and development, these hospitals, how much these community hospitals are there. So it's or like tertiary care, primary care, what sort of care is available there. So between the rural and the urban areas. So in urban areas, we expect there is better infrastructure.
Okay, fine.
So, yeah.
Does everybody agree to that? By and large, everybody agrees. How come Kerala has got such low then compared to all the others? Kerala is not the richest state in India. If it's about infrastructure, then Kerala is not the richest in this country. So how come Kerala has the lowest?
If I may say here, like I have been to Kerala, one of the parts like Wayanad. So I have seen, like the rural areas, they were so clean. There, like I couldn't see any, the greenery was there, everything. Like maybe like it's all about how we care about the environment and and also like Kerala have better facilities. So as compared to other states.
Okay.
So,
anybody else?
The sensitive
online or here? Yeah.
So awareness of accessing the healthcare also. So one of the reason in Kerala phenomenon.
Maximum number of nurses also come from Kerala. Also the literacy rate of Kerala is the highest in India. So the awareness amongst the citizens of Kerala is of prime importance in this particular data, and it shows very evidently that people over there know where to put their efforts and do what all things they should invest into and how to take care of themselves.
Okay. Since this is most students here are part of the development practice course. Also wanted to highlight that Banerjee and Duflo, when much before they got the Nobel Prize, they had brought out a paper showing the difference in development indicators of not just health but education and others, and they clearly proved that the reasons of it lay pre-independence. All the states which were ahead at independence continued to remain ahead till 2002 or 3 when their paper came out. 2 states which went down, states or provinces, West Bengal and UP. But the rest were very clearly, there was nothing which probably independence and beyond had done to their development indicators. They were very, very stark at that time. So the kind of work that the kings at that time had done in many of the states has been responsible for not just the society being up there, and that's why. So it's not that they have done great, but it was probably the work that has been done by their forefathers. Today, that has kept the indicators of Kerala very high, both in education and in the social structure. You may be knowing also that the best Panchayati Raj model in India is from Kerala, right? So they've got a very, very robust system of, if you remember rightly, I mean, last month, I think they declared that there's not a single person below poverty line now in Kerala. So they very confidently can state it up front that looking at all the indicators. So yeah, so Kerala is up there. But when you look at, we talk about one nation, one health, one nation, everything, one card, one nation, one. I mean, when you look at the stark difference, does it really look that that a child born in Kerala and the child born in Madhya Pradesh, I mean, don't you think a child born in Madhya Pradesh has the same birthright to live as long as possible from the same constitution? Why is it that this is so high? Why is it so different? So Kerala has done well, but I mean, even between Bihar and Madhya Pradesh, there's so much. Yeah.
Lack of education, lack of jobs. They don't have better infrastructure there, or if they have, then they don't have the staff they are working in the primary or the tertiary healthcare sector. So these things are missing there, or you can say corruption is the biggest thing, and also how much of people they believe in the quackery and all those things, and they do they say for example they don't have that much of money, they will go to the hospital, that's they have to spend money on that, then they have these available, this quackery and all those things, and they go to them, and that
but it could be there in Bihar as well, and
of course,
many other parts.
Of course. Yes.
Right. See, in India, health is a state subject, and things were very bad and very diverse earlier. But from 2005 onwards, the central government took over and started funding the National Rural Health Mission, and which is now called the National Health Mission. Right? What we used to see earlier is now not as starkly different as today. Yet, why I wanted to show you is that public health systems, I mean, public health is not dependent only on the public health system. A lot of it is society, family, the hierarchies in society itself. All those lead to the different outcomes. And as I said, infant mortality is considered the most comprehensive indicator of health. It's funny that we are dealing with health with a mortality indicator, which I say is an absence of life itself. Forget about the disease or illness, right? Okay, let's go to we'll come to it. So this, I think, is a very important part of public health. If we know this, so I'll show you a graph. It's scanned from a very old book. Can somebody try and take a shot at this? What are you seeing in this slide?
So over the years, the TB deaths have declined per lakhs. Say if you talk about 1815, so 120.
So this is about UK. Okay, I mean, so it's not mainly in England and Wales. And yeah, so what do you see first as the graph? The TB deaths have dropped from
120 in 1850.
Yeah,
if you go to the
120 deaths per lakh population from 1850 till 1990, practically. They've shown this because this, right?
And then we see TB was this bacteria in 1882. It was identified, and then when we started to bring in the medicines and provide information to the people, so then it has slowly
and the BCG came up only in 1953, and the first medicine came up only in 1947. So what hits you? What hits you from this? So is Okay, just to cut short the time, do you think medicines are responsible for bringing down the deaths of TB, or is it something else?
No, it's, I think if we see here before 1950s, we see like it has been declining. So it is when it was identified, like people I think got aware about it, and they started to take care of the things. And maybe like I don't think so. It's just the medicine thing. Yeah.
Okay,
If you
anybody
see
else?
like it's almost 20 here. If you see when it was identified, it was almost 20 or 25, like between 20 and 40 we see here. So from 120 to 20 and 40, like it's a huge, difference here. So from 20 to 0, it took almost like, some 40-50 years. So, but it's not like medicine alone here. So
Yeah.
I feel so.
Thanks for that. Anybody else? Yeah.
I believe it's a cumulative effort of community public health efforts as well as medicine. Medicine, however, in this case, as per the graph, played a very minimalistic role. Why I say that is because from 120 deaths to 80 deaths, it only took 20 years for people to realize what measures they need to take, what precautions they need to take, how they can prevent the disease, and how they can reduce the number of infected people. So I mean that in itself shows that people were aware and they were taking preventive measures. However, medicine in itself is talking of the times of 1850, it was not, we were not in such modern time, the technology was not that advanced. So I mean, like you mentioned earlier, it was only 1947 when the medicine was
Introduced.
So I mean, it evidently shows that it was the public and the awareness amongst the public.
Has anybody read Tale of Two Cities, Charles Dickens? If you read that, you will realize what was the condition of the air and the water in London in those days, right? Abysmal conditions, living conditions. And of course, England was on a rampage all over the world, earning and looting money from everywhere, but coming and giving it back to their people and bringing in many interventions which improved not just the living conditions, but included minimum wage, making it effective so that people at large, people who are working in the factories, working in abysmal conditions. So the government took charge of improving the water quality, improving the air quality, improving living wages, because people were not able to afford even a hot bath or even hot surroundings in their houses. It made compulsory how much of, in the US, most of these developed countries, you also have a law of how many people can stay per square meter of house, right? You can't live less than that. And if you can't, then the government is ready to give you housing. So it's about improved wages, how strictly a minimum wage act is implemented, how water and airborne disease can be controlled, all that, right? There was a bit of quarantine of TB patients was done in between in places, but as you very well brought out, that most of the thing was the burden of TB was brought down a lot, about 60-70% before the first medicines were available. India, when I finished my MBBS, we used to say that we lose 5 lakh patients, 500,000 patients per year to TB. This is in 84, 83, 84 when I became a doctor. Even today, the government estimates are 400,000 people are dying of TB even today. That's the government estimates. So we haven't done much despite having now availability of TB medicines everywhere, right? It's because the other determinants of health have not been instituted, right? We even have now free food for all the poor people in this country, but then we are not able to get it, ensure that all patients of TB and their families get. Just recently, in the last 5-7 years, there's some 2 or 3 brilliant studies which have come out from India, especially done by a friend called Dr. Anurag Bhargav, and he has brought out the connection between TB and food. even a village person would tell you that a poor person is more prone to TB. But at one time, I remember 1990s, the WHO person on tuberculosis actually stood up and said there is no connection between poverty and TB. He had the gumption to say that. But today, at least if not the poverty, hunger, the link with it is so clear. It's been clear for everybody in the village also, but scientists were not ready to believe it. And, it required two very great studies. And this last was called Rations, and where they actually gave rice and dal to families of TB patients also. And they have seen how, because every TB patient's family also gets prone to TB in the next year or so. So if they bring in food, it makes a huge difference to TB. And now the government has taken it on as a program. WHO has also accepted it, and we'll see more to do. But just trying to emphasize how determinants of health other than medicines actually make a role in diseases like TB, actually in almost in everything. This is from why both of us are here, is basically because northeastizing the mainstream is part of our agenda, and that's why most of the data that you will find in this 3-day module is from the Northeast, instead of only talking about Bihar and other places. So can you just anybody here or can explain these numbers from Meghalaya? What do you see here? And this is again from NFHS. It's very good that the National Family Health Surveys now are checking on different determinants of health also to see. What do you see here?
Like, more educated the mother, we see less of mortality, neonatal mortality, infant mortality. So it's like as mothers are more educated, there is less chances of having all these mortalities.
Anybody
So
else
like,
who wants?
you can say,
Yeah.
indirect relationship between.
Does everybody agree to this?
Yes, I mean everybody. I mean I agree with this. However, the last 10 or more years does not comply with this statement, wherein the mother has been given the education for 10 or more years, and the neonatal mortality is 13.3, which increases in case of infant mortality to 17.8.
Because that neonatal mortality is the first month, right? And after that, infant mortality is the first year, and under 5 is then a total cumulative over 5 years, right?
So it also like this, if a mother is 10 or more years of education, that means like they will have a fewer child and they will be taking care of their child more. And if we like compare to the mother who has not who is like no schooling or so like more education, they will tend to have lesser children, and they will tend to have they will it's like it will be like automatically like they will have lesser.
Okay. Anybody else who wants to comment on it? The things are very stark here. Very clearly, all the mortality rates for each age group is lesser when it's. Why did you say that it's an outlier? I mean, you said it's not conforming, the 10 years or more.
I mean, it is if we look at the infant mortality and the under 5 mortality of the upper ones as well. Yeah. However, I mean, it should have been equally less. I mean, it could have been even
lesser. You mean? Okay. Yeah. This is a slide which I love to show because, in one sense, if you remember, I said infant mortality rate is considered the most comprehensive indicator of health when you have to compare one state with another, one country with another, or one society with another. So clearly here, if you had to improve health typically and see it only with one indicator called infant mortality, the best is to invest in the education department and focus on girls. Am I clear? And this, when the first time the study came out, was from Nepal, and then it was tested out in Bangladesh, South Africa, and then in India. And everywhere the results were the same. 8th standard to 10th standard pass mothers, we still don't have a very clear picture why this happens. It's for all the reasons that somebody mentioned, online, and it's maybe they have fewer children, maybe they're more aware, maybe they're more confident, maybe their families are more confident of them taking them to a hospital. But the effect on infant mortality rate, the effect of the mother's education on infant mortality rate is more than the effect of number of doctors available in that area, number of nurses available in the area, immunization rates in that area. Much more than that is the mother's education. Right? So it's a very, very interesting study which came up and woke us up all over the world. And now NFHS at least tracks this and tries to put this starkly in front of people so that they know where to invest their money and time into. Right? Is about girls' education. Okay. Again, I mean, this is basically to highlight that the factors determining health indicators are outside the typical ambit of health and family welfare. Total fertility rate, I would like to define because not many people here are from medical backgrounds. It's kind of an average woman in the age of 15 to 49, which is the reproductive age group, right? So roughly how many children would an average woman be giving birth to, right? So that's what the total fertility rate is. And look at this. Just by the residents. Yeah. More than. The rural is more than double of the urban, right? Now, the reason is not just one, the residents. Maybe it's the economic factor. Maybe, I mean, as somebody said, the access to healthcare is more, right? But here it's not about infant mortality where somebody has died because of a disease. Here it is about preventing your fertility, preventing your child from being born. Maybe the woman feels trapped in a society, which looks at sterility badly compared to a urban area where she feels more liberated and families can decide on their own to have less children. Maybe in a rural area, they're prone to social pressures more. So we still don't know exactly the reason, but we know that this makes a difference, right?
Sir, can I add?
Yes, please. Come on.
Agency of the woman also the another factor of this. I mean, if the woman wants to undergo for the sterility in rural, because they will get the pressure from in-laws and both their parents.
That's exactly what I was saying. Yeah, the social pressures are far more in a rural area that they may not be able to decide even if they want to. Correct.
Along with the social pressure, they also have if the woman from the urban, most probably they are much more educated than the rural, then they have the agency to tell their opinion or.
Right, correct. I mean, that also plays a role that the more educated the woman, maybe she's getting married to somebody more economically better off and then staying in the urban area, right? Getting into a job and into an urban area, right? So prevents, makes the access easier to sterilization or even their own decision making. Is that okay? Understood? Now, I also wanted to mention here that, when we look at a total fertility rate per woman, we normally talk about 2.21 as the ideal at which a society will become stable, a population will become stable. Why? Because a husband-wife means two people having two children, and we allow a small 10% margin for children to die early or something, so that two people are giving birth to two people, and then society manages to be at a level population for a longer period of time. So 2.1, we call it as a replacement rate and is considered to be the ideal, right? At which society's population can then be constant. Is that understood? So a replacement rate in TFR, total fertility rate, is considered to be 2.1. And so look at this in Meghalaya, the urban one has dropped much lesser than that, right? I want you to see the next point, or the Muslim one is not see. What do you see from here?
So it's a difference in TFR between like different religions. If we talk about the Christians, they're the the population of Christians is more in, I think, Meghalaya, and that shows, they tend to have more children. Christian women tend to have more children as compared to the Hindus.
Because they are Christians or because they have more population? More
Maybe they have
population means
more
the percentage.
population.
So would that lead to a higher birth rate?
Not necessarily, not necessarily, but like it's all about, like, we talked about the reasons. Like, it may be the society, it may be the how much they are educated, how much the economic conditions, how good their economic condition is. So depends on that also.
We can't see the out here. What's the Muslim rate that you can see?
I can't see. It's 1.43, I think. So it's like,
Okay.
if you can hide that thing, I can see. Is it 1.43?
I also can't see it immediately. So
it's a hide thing is there. There's a hide option. If you can hide it, this link.
Yeah. Compared to the this man. So I just wanted to highlight this, that often it's not. You can hide it if you can click on that. उसके right side में है ना
hide option, yeah,
with the mouse. Oh, okay. वो hide कर सकते हैं क्या नीचे? Second वाला.
Yes. Yeah, it's this one.
Oh, ये निकाल हो गया. ये है? इसमें लिखा मेघालय, you were right. नहीं, दूसरा वाला होगा. Change किया था. Yeah, 1.43. Yeah. Thanks. So, people will often throw figures at you, right, and kind to convince you कि देखो Christians का ज़्यादा बच्चा पैदा हो रहा है. It's not always a thing of just being a Christian or a Muslim or a Hindu, right? There are other factors also which play. So that's where determinants of health, and we'll also talk about intersectionalities later on. We need to keep that in mind, right? These are typically all the people who are Christian there, mainly are scheduled tribes. And we know that scheduled castes and scheduled tribes in India, they have a higher TFR compared to all others in the country, right? So it's not about the religion as such. And if you think that, okay, the Muslim one is almost double that of the Hindu, let me show you something else a bit later. What do you see here? If Christianity was making a difference there, how come not in Assam?
So yeah, as I said, like it's not just like there are different various factors here. Like if you talk about Assam vis-a-vis Meghalaya, then we have the economic conditions, we have the terrain, we have different. It's different various factors are there responsible for all these things. So it may be different in if you go to the Bihar, if you go to the Madhya Pradesh, if you go to the Jammu and Kashmir. So things will change. Things will vary between all these religions. So there are different factors responsible for that.
Yeah.
Just wanted to add for Meghalaya, if you see, it is also related to identity. It's a small tribe, and the fear of losing out on their, size of population and their identity. The community pushes for bigger families and more reproductive because of the whole identity crisis and the migration happening into the state. So there is a push for increasing the community.
And behind that, possibly also there is a majority-based democracy which is at play, because you want to have your own government, which is represented by you. So there are linkages there.
If you look at the Indian democracy, the population size decides the number of MPs that you will have, and that is where there is a sense of feeling of neglect for the region because you don't have enough representation. The resources don't come into the region. So it is much larger in terms of
So yeah, like talk about the identity, like we don't know. We have seen like TFR has declined overall in India. So now we can see like if you read the news, we like nowadays we always see the clarion call for increasing the population of Hindus, like by so many gurus and all those things. Like we are hearing now all those things in news now. We have to increase the population of the Hindus, this, that, and all. Women should bear 4 or 5 children. So this may change maybe in future also. Like we don't know.
Yeah. So on one side, the government was trying to push for a lower fertility rate of everybody, and now the religious people are now pushing the women to have more children, right? And it will be a very interesting play over the next 15, 20 years how we manage this, because we know that in Bombay there's been things for only Maharashtra for Marathi Manus. We've had Karnataka about language issues. So where we don't like the outsider, how this is going to take play, the play on society, how you will require to look after the industry, to look after the caregiving. You will require people from outside, mainly from Bihar and UP, who have refused to cut down on their TFRs actually till date. Compared to all other places, they are still making up for above 3 TFRs, both Bihar and UP. Even MP has started cutting down. Let me look at this. If you thought that Muslims have a higher TFR, I just want you to take a look at this one. J&K, which has 68% Muslims, it has the lowest TFR in the country. I mean, till it became a state. I mean, it's a UT now, but till recently, because Ladakh's population is very small. So it has the lowest in the country. Muslims are at 1.45, Hindus at 1.32, and Sikhs at 1.41. So is it the religion which makes, right? So this is one of the things which, that we need to be very careful when we are just throwing one statistic from one place and then extrapolating it and talking about it for the whole country. We need to look at, if it's religion, then every country in the world which was predominantly Muslim would have a very high fertility rate. It's not there, right? Similarly, within India, I'm trying to show you the one which has got the maximum population is not doing this. So is it that where, again, as Sinakshi said, where there are minority, there is a pressure, social pressure to increase their population, or at least not be as progressive as others? So so how do you deal with it? Do you deal with it by making people more comfortable or more protected, rather than, so if we know that in biology, any species under threat will try to procreate faster and bigger, right? In higher numbers, right? So do we take away the danger to them and thus give them protection so that they will have a lower protection rate, or should we force them into a lower fertility rate? So that's the debate. Karan Singh, when he was health minister for some time, he went to the UN. I remember his statement saying, development is the best contraception. And Kashmir has had one of the best public education systems for a long, long time, right? Even in the 50s, the teacher would be going along with the nomadic tribes up the hill. You'd be getting a pony to tie up a tent and whatnot, and he would be teaching the children up there. 1950s also, right? A very progressive education system. And if English is the criteria, anybody who is 10th standard pass in Kashmir would be able to speak grammatically correct English. May not be the great accent, but their grammatically correct English would be there and it's gone through for 30 years of insurgency, and still some of the standards are maintained, right? So it's about education again. As I was saying, a lot of the things depend upon the mother's education, and then this gets passed on with every generation down to.
Okay. It's also like in J&K, we have like average age of woman, marriage. So that has like gone beyond, I think, more than like 25, 26. Like I see like there are women who are not getting married,
Correct. I mean, that's also there.
That's
but I mean,
another reason.
That's not just because in Bengal, I think, both Bengal and Tripura, where there are plenty of Bengali population, marriages, most girls would get married only after the age of 25. Yes, that's true for Kashmir as well. So that also makes a difference. Yes. I now bring you to another very interesting study, which I think as public health people, we need to understand. And this came out from the Whitehall study. And this is again done in the UK. But it has made a difference to the world's understanding of health. And have you heard of Whitehall? It's like the Central Secretariat of Britain. Right, where all the central government people sit, all the babus and everybody sits there. And so this was Michael Marmot. He started that, and Michael Marmot actually has been responsible for, I would say, the backroom pushing for the SDGs. Have you heard of SDGs, everybody? The Sustainable Development Goals. In one sense, these are all determinants of health. All that is in the SDGs are determinants of health, and he started this, and now it's going through, I think, the 7th or 8th phase. This Whitehall study is going through. So the first time it was done, they wanted to check out, in a very socialistic system where the NHS, we've all heard about how efficient the National Health Service of the UK is or was at one time. So they were wondering whether they've really made the difference. They've really socialized health or not. Because I've been in the army, and I can tell you that we had one disease, one diagnosis, one treatment. It would not depend upon a general will get a better treatment than a soldier will get. No, it would never be. The similar thing is in the NHS. The Queen also, if she gets admitted, will get the same treatment as any laborer will get. Right? She might get a separate room because of her security, but otherwise, there will be no difference in the specialist who's looking after or the treatment or whatever. Unlike what we see in our country where, money decides or social status decides what kind of treatment you will get for anything. So they try to check out that is it making a difference is it really socialized? Are death rates, and, are they equal or more or less equal in all the sections of society? So as a proxy, they took the Whitehall because, they're all government servants working long term in one area, and they wanted to follow them up long term and try to see, is there a difference between the uppermost layers, like what we call grade 1, grade 2, grade 3, grade 4 posts? Is there a difference or not? And they found there was a stark difference. Actually, it upset them because they were thinking that health is something which levels all sections of society, right? Just like education can. So they were feeling that they've, really socialized health, and hence everybody would be equal. But what they found was that there was a very stark, clear, this is heart disease, coronary heart disease mortality. When they checked that, they found that the lowest classes, the janitors, what we call chaprasi, and that kind of levels, the death rates were the highest. They also found actually that, though we might think that the people who are richer would have higher cholesterol, but they actually found that even there, the cholesterol levels and the smoking and blood pressures were much higher in the lowest classes of society than in the upper class. So initially they thought that, okay, maybe, that we are only studying mortality, and it's possible that people who were poorer were staying away from the city areas, or, or they didn't have enough, the ambulances would reach not in time. They didn't have cars of their own, so they can't rush the patient to the hospital. Maybe that's making a difference. So they went into the second phase and then the third phase, and they kept neutralizing the effect of any material acquisitions that a family would have, the kind of house, car or no car. They kept neutralizing that by well-designed studies, and they found that this effect across the status, the hierarchy in society, continues to be there. Look at this. again, Marmot study in 90s. Now we are going through, I think, the 7th or 8th phase of this thing. And now they are doing it on, they've done it for mental illness. They've done it for, cardiovascular illnesses, accidents. Everywhere you find the same gradation. For any item that you see, they found that the mortality rates are much higher for the lowest classes than for the upper class. Any idea why this would be there? Because we normally say ना कि ऊपर वालों को तो बहुत टेंशन होती है, 24 घंटे काम हो जाता है, प्रोफेशनल्स एंड टेक्निकल पीपल इनका तो रेस्ट भी नहीं मिलता होगा. Why do you think that the people who are at the bottom most, and there, I mean, comparatively, it's an 8-hour job for a lower class, I mean, a janitor or a driver or somebody. But why do you think even mental illnesses there are higher in the lowest classes than? What do you think is the reason?
Diet.
Work pressure.
Why diet?
The quality of food. I mean, a person would. I mean, comparatively, relatively, if a person who is a janitor or is working at a clerical position might not be aware as to what should be consumed in how much quantity. First, also, if we say, like you mentioned, smoking. So if an administrative class person is smoking, he might be smoking a good quality tobacco. Whereas if we compare it to the janitor, he might be smoking a bidi. I'm not saying tobacco is anyway good in and should be consumed, but I mean it makes a lot of difference in whether you're consuming direct smoke or it is getting filtered. And I mean all of these things once, I mean you come from medicine, all of these things once came as treatment for things for certain ailments, but now they have become lifestyle disorder things and have led to, because of excessive usage and because of abuse of such
Okay.
things.
Anybody else? Okay. Yeah, fine. Anybody
Yeah, so
else? Yeah.
I think there is a difference between approach. The upper class, so-called upper class, is more of a preventive type, and these are curative type, lower class. So chronic disease ka there is a proliferation of chronic diseases.
Mind you, the NHS business model is such, it's a per capita payment model. So a doctor per family will get the same amount whether he's ill or not. So there is vested interest in keeping them healthy. So their health awareness campaigns are very good. Their medical checkups are much more common because they would get the same money if the patient is ill or if the patient is healthy. So they obviously try to do their maximum to keep people healthy in their system. Right? Unlike our per capita income, which is based on how often you fall ill and you'll get that money more and more. So there's an incentive to allow people to fall ill. Right? Okay. For cancers, chronic lung disease, CIT, depressions, everywhere this thing refused to go away. This linkage, this clear hierarchy of deaths and disability being higher in the lowermost classes came out to be higher. And now we say that's probably, we still don't know the exact cause. One of the clear things is about low self-esteem in the lower classes, right? And the inability to decide for themselves, the unpredictability of life. They can't decide on their holidays. They can't decide on their, when they'll do what, right? They could be getting, but people on the top of the hierarchy, they can very often define their life or make it more predictable. So the stress and stress which is caused, we often say the upar mein bahut stress hota hai. Actually, that stress is still more predictable compared to people down below. And we feel that it's because of the cortisone, which is produced because of being under stress. And that gives rise to more and more diseases, from diabetes to hypertension. All that is higher in the lower strata. This is a very important study, especially for India, I would say, where we have various forms of hierarchy, especially in our caste hierarchy in villages and all, right? Where we've not even thought about all this, and we just think about the physical factors which bring in disease. This kind of thing where people are facing low self-esteem, the SCs, the STs, even the OBCs keep talking about it. And then the kind of discrimination that they have to face very often, all that adds the burden when you're looking at mortality and morbidity rates, because they don't get treated fast enough, they don't get treated well enough. All that also adds to the. So I'm just concluding here, more or less, that the determinants of health often come from the social and economic environment. We are all talking about, we are in Delhi NCR, and the physical environment, definitely the AQI levels are so bad that ideally we shouldn't be running away from here, not staying in Delhi. We tend to blame, as doctors, we tend to blame the person for his or her illness. And I think we need to do away with it. Yes, at the core, there is often some genetic factor, some familial factor, some hereditary factor. Yes, there is there at the core. But a lot is shaped by the things around. And I'll just come to one of the pictures after this. So we all know that we often talk about middle income, higher income, lower income groups as if it's only about economic. The Chakravarti classification of social gradations in India from very, very early clearly brought out that it's both social and economic. So it's not just whether I have a car or मैं कार वाला हूं कि बेकार हूं, right? उतने से नहीं है. It's about how much of, what kind of contacts we have. A person with, I'm sure all of us here, when we go to a doctor, first thing we try and find out is there a connection? Do you know of some doctor? Am I right? All of us tend to find some relation who will get me to a doctor, because we don't even trust whether that person will be nice to me or will look at me carefully, because maybe he doesn't have time. So if I have a go-between, I tend to trust that. It's much lower chance for a person with this low social status to have somebody in the family who's a doctor. He at best gets to some grade 4 chaprasi or somebody running in a hospital in Safdarjung or an AIMS who will be able to show me to a professor there, right? So it's not the same. Whereas people like us, sometimes, many of our friends and relatives would be doctors and would be able to gain that. So it's not just the income, it's about, the social contacts that we have. Education, we've already mentioned. I don't want to talk about it too much. And safe water, we know for a long time, clean air. Today, we are talking much more about the workplace. Because 7-8 hours a day we are spending at our workplace. And our working conditions there make a difference. So we are very clear now. In fact, it was very nice to read a report on typhus. I was reading a report in typhus in the 19th century. And this person writes out there in the report, autonomy, autonomy, autonomy. He's written it then that this will make a difference to the mortality rates from typhus in Austria, a very famous doctor. And so the lesser the hierarchy, the lesser the pressure, lesser the dadagiri in the workplace, the health outcomes are better, even in workplaces. So I just wanted to link that when we looked at the Whitehall study, that's what it shows. The lesser that, if you can mitigate the levels of hierarchy, if you can mitigate the challenges of hierarchy, where people can decide on their leaves, people can decide on the time that they are in the office, people can also, to some extent, decide on, when they can be measured with their outcomes. The health outcomes are better in them. Right? As I said, That's not the place which will guarantee your health, but it's making a huge difference to your health, because we are not just staying in houses now. Most of our time, most times of the week, is spent in the workplace for many of us. Your social support networks, as I said, already make a difference. Gender makes a difference. Access of services, which we all talked about earlier. And I also, I wanted to remind that, we very clearly saw that in infant mortality, it's the education of the mother which was more important than even the access to health services, right? So we need to even understand the gradation between these determinants of health. They can act very differently. And so again, I'm mentioning all this, how a child develops in the first 1,000 days of life, makes a difference to the health. Whether the person has been exposed to violence or not can make a difference on their behavior themselves, proneness to violence, as well as mental illness. Core, the number 10, which is there, the biology and the genetic endowment, that's there because it makes we know nowadays that some people are more prone to certain diseases, even like diabetes or this thing. But then the others play a much bigger role. So the individual, my point is that we should not be blaming somebody for the thing, because most of the determinants of health are outside. Even your behavior is controlled by the market, the advertisements, the kind of money that we spend on health. We don't, these days, we would like to be seen to be caring for our parents, and we'll take them to the most rich and expensive place for treatment. Even though sometimes we know that it's a lost game, and we might be even, in one sense, selling away our land and our assets, which could protect our children. We would spend it on somebody's illness at the end, so that we don't look bad in front of our relatives, that we didn't do enough for our father or mother. Although it's what we call a dead investment now, sometimes, right? So a lot happens because there's a social pressure on how we behave towards health. What's our health behavior like, right? It may not be logical at all. It depends on the market, how it produces. We all know, I think, most of the medicines, the actual price at which a medicine leaves the factory is usually 2.5% to 5% of the MRP. With the 20% profit margin for the factory to produce it, usually it's between 2.5% to 5% of the MRP mentioned on the thing. That's what you can get the medicine for if you were to buy in bulk. But then these promotional expenses, as they call it, are very high, 30% to so and so, 20% to so and so, and the cost builds up. So it obviously makes a difference to the even the procurement by the government. So Tamil Nadu today has got the best procurements. I think they actually buy most of the medicines from the best companies at 2.5% to 5% of what they are selling it in the market for. You can go to that TNMSC, there's a Tamil Nadu Medical Services Corporation website, and you will be shocked at the levels of cost that they're buying. And now they've got set up even for equipment and machinery, or even lab diagnostics. They've set up this thing so that people know, benchmark it. That, okay, if we bought it at this price, maybe if you have a lesser population, you might pay a slightly higher price, but you don't have to pay MRP. But people are not even aware. Even the government doctors sometimes are not aware of this difference. So they end up paying a huge cost for what they are trying to introduce in a government system. So there are multiple levels of influence. So one is your intrapersonal or individual factors, then interpersonal, the effect of the mother or the mother-in-law on your fertility, or, where you will take for treatment. And then whether your institution provides medical insurance or not, what is your leave policy in the organization, all that. Then certain community factors come in, on how you see health. how you allow or not allow. I mean, some people, like some religions, will not permit contraception, for example. So a mother would be more prone to maternal deaths compared to others. And then, of course, public policy, because it depends finally on how much a government wants to spend, how much of, invest in terms of money, the best brains. You often seen health ministers as one of those, कुछ नहीं मिला तो चलो उसको यार वो women's welfare या health देते हैं. Right? Somebody who's not very politically savvy, he's given health or something like that. It's not seen very much high in the hierarchy. Economics, finance, defense, home, they'll be given priority, not health. Whereas all of us, when we are looking at life, we are looking at a happy life only because of health. So somewhere we don't prioritize this. So we can send you this thing. You don't have to copy it or whatever. So there are plenty of policy factors, right? So we can give you these notes later on, right? Any questions by people there? This is one. I want to end with this slide. This is from a UNICEF report. And they looked at under 5 mortality rate, which has changed dramatically in 20 years from 1990, as I told you, from 84 to now. Under 5 mortality rates have come down to 20% of what they were earlier. And you look at how much of it comes from actually what you would call health and family welfare. It's only, if you look at the right side, the health service delivery, immunizations, fertility. That's all that the health and family welfare is spending on. Am I right? The GDP per capita is decided by your policies, the economic policies of the water sanitation department is a separate department. Education is different. Infrastructure, and then technical progress, IT and whatnot is something different, right? So the effect, the factors which affect change are very different. And the factors which make impact on it are also making only 11%. The rest is. So I'll not go beyond this. Just wanted to highlight that the determinants of health are very often, when you're looking at mortality rates, it's very little is handled by the health and family welfare department. And that also, if you notice, health service delivery is a very minuscule part. It's the immunization and the fertility which is making a difference. Can you see that? So it's a preventive part which is actually making more of a difference than the health service. Yet when we ask for health, kya chahiye? Doctor saab chahiye, hospital chahiye paas mein. That's not the way to go about. And there was an interesting study about 30 years ago. London School of Hygiene and Tropical Medicine did this study and tried to map maternal mortality, which women who are dying during delivery or within 6 weeks of it or during pregnancy, and infant mortality. And they were trying to map this according to the number of doctors or the density of doctors in that area. And they found there was a direct correlation. Wherever there were more doctors per capita population, per 1,000 population, the higher the mortality rates and the higher the infant mortality rate. So when the study came out, it disturbed a lot of the doctors. Sharam aa rahi thi. We didn't know how to describe it. And so the doctors tried to save themselves by saying that wherever there's high mortality, that's where the doctors go. We know it in India, it's not true. So then they did the second part of the study. They said, okay, if that is the logic, then there must be more nurses and more hospitals also out there. So when they checked the density of beds and density of nurses per 1,000 population in those areas, and this was done in the US, UK, and Holland, they found that it was inversely proportional. Wherever there were more nurses and more beds, the mortality rates were lower. And they left the study at saying that we leave the doctors to their fate. I can't explain this any further. But so this is just another way of looking at it. And so any questions, any comments, or else we'll break for lunch for some time.
Okay, so can you hear me?
Yes, please.
Okay, so thank you so kindly. I'm so grateful for the lecture. I mean, it's really inspirational. There's this concern that I have. I've asked this question over and over, and yet can't get the straight answer. And I just hope that I can get some answers. This thing about tobacco losses.
Yeah.
If smoking cigarette is so dangerous to our health,
Yeah.
why is it that the government can institute a measure that will absolutely curtail it so that nobody can smoke?
Sorry, can you come again? I mean, I just because kind of communicating with somebody else. Can you just come back again with the question?
Okay, so I'm saying,
Yeah.
if smoking cigarette is so dangerous to our health,
Yeah.
and it's clearly written on every cigarette that it's dangerous to our health, is there any measure that the government can put in place to curtail it so that it cannot be smoked, so that nobody can take it in?
There are no easy answers to this. I think in India, we banned cigarette smoking in public places. And I can tell you in India, we really, I mean, I also never expected the kind of drastic reduction it would make in smoking in this country. Right. So that's one, by banning it. Because earlier, the typical thing was increasing the prices of. But what we had seen very clearly in sociology of medicine, when we were doing social studies, we found that smoking was not about smoking smoke. It was more about feeling good, or kind of giving self-esteem by smoking, and blowing the smoke in somebody else's face, or just being there. So we found that whenever we raised prices, it was the richest people who, out of that people, I mean, out of all the smokers, the richest would move from there to some other part where they could keep their self-esteem, or so this whole balance between smoking and self-esteem, it was as if like a marker. So the richer that person was went off smoking, but the poorer people stuck to smoking and were now spending more money on smoking. So they were having now the highest amount of cancers and whatnot then. So that's where it's become a kind of a thing that we banned public smoking, at least. And of course, awareness that even the family would get. The side stream smoke is even more. Yeah, if we could just, the worldwide, if we could have a ban where we destroy all tobacco plants, I think it would be even better. But then also realize that there are more ways of addiction. We have addictive personalities. People like to have addictions of various things. So if we don't die of smoking, we'll die of something else, right? So there is one has to draw a line somewhere. But I think we've done very well, because every person who was smoking was also an advertisement for smoke. And that was cut down with public smoking being banned in this country. So I would still I would say that's probably enough, and also teaching people the awareness not to have. Is that answer okay for you?
Yeah.
Thank you. Yeah. Anybody else? Yeah.
I got a little statement to make in connection with the question posed. The issue about smoking being banned has to do with the law.
Yeah.
From the perspective of legality, one looks at territorial jurisdiction. In some other countries, smoking is actually illegal, and it is squarely and simply in their law. And if you go beyond or into another country, it is not bound, it is accepted. So to speak collectively in the context of banning smoking everywhere around the world, it's like looking at the issue of HIV. So you will know that other countries have laws on that, and some other countries don't have law on that. And in the context of territorial jurisdiction by law, you have other atoms that are illegal and other atoms that are not illegal. So you got to speak in connection based upon the case study and looking at your country, because for us from Liberia, public smoking is illegal. When you are caught, the law takes action immediately. And I think from my perspective, it got to be viewed from that direction.
Yeah, I just wanted to say that, in India also, we never thought, though we have a religion here which doesn't permit smoking. We had the Sikh religion in this country which didn't permit this thing, and you would rarely find a Sikh who would smoke, right? Even if the tendency is from, looking at other people, he won't smoke. But then when we brought the law, people like me also never expected the law to become so effective as it did, because it brought social sanction to people to tell somebody off. Earlier, that was not there. With the law coming in behind it, there are so many laws in this country which nobody follows, right? But smoking really became very effective. I can say that very confidently that it's not even 10% of what it was about 20 years ago. And it made a difference by law, of course. And I've hardly seen anybody who's been arrested or even fined because of smoking. Just that all public spaces had to put this up, saying that, you are not allowed to smoke, that you are not allowed to sell smoke, cigarettes in the trains and in public buses. That just made a difference. And we didn't even have the best health minister in those days, but some things happened. I mean, I think the society was just waiting for a law. So maybe that's also a factor.
Yeah, I think on that too, the public health sector has more responsibility.
Yes.
You will have to do more publicity to inform public policy makers that this is dangerous. So we can campaign against it in a unanimity formation, informing the lawmakers that you can ban this, make the law effective, make sure that it takes its course. Anyone who will be caught will be dealt with immediately. So the person who is not a health practitioner does not know that it is dangerous. She or he takes it in based upon self-esteem. So public health workers or practitioners need to do more work in that direction.
Yeah. Anybody else, or we'll break for lunch for some time? What time do we get back? Is Gayatri will. Yeah. It's 13:34 already, so that's what I'm saying. 2:15, 2:30, 2:30. Okay, let's get back at 2:30 then. People online, right? Thank you. कोई नीचे आ जाता। Yeah. Welcome back. Good afternoon. I hope you can hear me and see the presentation also.
Yes, sir.
Okay. Thanks. So we'll what we plan to do is we'll yes, anything?
Yeah, so we can see the presentation.
If we can. Okay.
We
Yeah. So
can.
we'll go ahead. So we'll just talk a bit about equity. And what we plan to do is in between, after about half an hour or so, or maybe less, we will play a game. Of course, there are not too many people here, and we don't know how to play it with the thing. So I hope that you'll all be in kind of at least listening mode while we are doing it. And we'll try and involve you in giving an identity to you online. And then you can choose one. Let's come to that later on. Okay, let me just start with equity. We've heard the word equality a lot. Do we understand equity? Have you already done it? I don't know, in the course, or how do we differentiate? Can anybody?
Equality is basically when we provide anything equally to somebody or people. And equity, on the other hand, is when if there are two people, right, two person like A and B, A has 80, B has 60, to make them equal or to make them on the same pedestal, one needs to be given more and one needs to be given less. To make them at the same, to bring them on the same pedestal. So that is equity.
Wonderful. That's quite simply explained. Yeah. So equity is a concept that we talk about as a concept of trying to bring justice into society, try and creating equality, because now, unlike older times, I mean, abhi ek ye ho gaya ki all of us are equal, right? But is that a esoteric concept, or is it a duty of a state or a society to try and, right? Yeah, so that people really feel a sense of equality. And so there are various measures in which we do this, and we look at equity and inequity. So I'll try and, I think it's very well done by this slide. Can you see how this works out? So the second one is about equality, where everybody has got, the same benchmark in one sense, but then it's discriminatory for people who are born short or maybe who are young in age, right? So the person who is on the same, so we are very happy that, okay, we provided equal benches to everybody or equal stools to everybody, but it doesn't work out because the person who is short is unable to see the football match or the golf course, whatever, right? Equity, when we talk about, is about distributing your interventions on a justice basis or on a fair basis.
So
Right.
sorry.
Yeah.
Hi. We can't see if you are sharing the slides.
Okay, can we just check? Okay, fine. The second slide is not visible to them. So kindly, फिर से वही वाला problem हो रहा है शुरू में. That's okay. I'm also aware of the fact that it's the AQI which has done it. So people can't be discriminated because the air was so bad.
You have stopped again.
Yeah, I know. They're trying to repair the thing. See, technology also brings in inequity. People here can see it, but people don't.
Just hide it. Click on hide so that this. Control F कर दो, it will be full, I think. Using Control F option, it will get full. Go into the view above, right in the corner. There is view option, maybe. Yeah, and do it a full screen. Yeah, there's option of full screen on view.
कल भी यही होगा नहीं because people are asking me. Can you see the new slide with 4 boxes?
Yes.
Yeah? Reality, equality.
Yes.
Oh, great. Thanks. Thank you. So the first one which I was showing was equality, that we tend to feel that everybody is equal, कि हमने अपनी ओर से सबको बराबर बांटा है. Right? Or so we have given a stool to everyone, but it's not effective because the person who is tall manages to get the, or the richer person is in real life, the richer person can grab all the resources, but the poor person, उसको हम बराबरी के चक्कर में वंचित कर देते हैं, So sometimes we have to take this equity wala, what we call positive discrimination, reservation systems in India are meant for that. Okay, those who have already achieved something, those who have the capability, we don't give them anything, say. We just, but we help those who really need it. So in one sense, this is called justice-based or, demand-based, need-based intervention. So we call this positive discrimination. We use reservations a lot, in India for castes or, tribal people or for OBCs, just so that we see a sense of equality at the end of it. People can keep challenging this, that, there's never an equal world. But I mean, our job as administrators, as governance people, is to constantly look at ki kahan inequity aa rahi hai and how we can balance it after some time. Because anything will probably, and there's a common phrase हमारे यहाँ बोलते हैं कि equality leads to iniquity. So this was a very famous thing एक time पे जब उन्होंने बोला कि अगर आप if everybody reads, suppose आप बोलते हैं कि हम हिंदी में सबके लिए पोस्टर बनाएंगे, तो those who can read Hindi, they will be able to get aware and correct their behavior, but बाकी तो नहीं कर पाएंगे. या जो somebody who doesn't even know how to read, वो तो पीछे रह गया ना. तो gap between the haves and have not will keep increasing. So, and that's not healthy, because and that's the most important thing in that is when we measure equity or inequity, we look at something called a Gini coefficient. And the Gini coefficient, जिस समाज में ज़्यादा होता है, वहाँ पर, I mean, wherever it's the Gini coefficient is more, you need more police and army. There's more violence in society. So if you really want to do away with wasteful expenditure on Home Ministry and the Defense Ministry, it's more important to have an equitable society. And that's the reason why we are looking at positive discrimination or reservations. So I also grew up probably, saying that kyun zarurat hai reservation, it's not meritocratic. But over a period of time, you realize that how, unjust the system is, that people get left behind. So that's where the equity is. Of course, somebody has to constantly look at why is the barrier necessary? Can we remove the barriers? And that is what brings liberation that everybody can then enjoy. But is that possible sometimes? Because people have argued with me sometimes that why do we need reservation even in a train? Why can't we have everybody to? Yeah. But then one has to argue that, how will women with children climb it and, get a seat? Or, somebody who is disabled, how will he ever get a seat, he or she? Right? So we need some kind of reservations for this. And the similar thing is for jobs or other places. And I'm not trying to say that it should continue forever, but I think we need to constantly look at who gets left behind and how do we now bring them back into the picture. Right? So it could be any community, caste which gets left behind after 30, 40 years, you do a reassessment and then have certain amount of positive discrimination for them. Right? But the reality is what is happening on the left side, that, somebody is really into the dungeons and somebody is really standing, towers above. So that's one thing which bothers me also, because, when you look at Western countries, which are really maybe rich or developed, whatever you may call, they had this system that all education, at least till the 10th or 12th standard, everybody will have to go to the same school. There were no private schools practically, right? But in a system where you have private schools which are rich and which have, a good quality of education compared to other government schools where there's poor governance and poor education, then what happens is all those people who get into jobs are only those who don't even understand the poor. So you have a society which worsens it over a period of time. And education and health, generally people feel, should be in the public health system or public education, public health system, so that people tend to start believing that everybody is equal. Otherwise, this reality that we see on the left side keeps getting perpetuated. This is yet another showing, three terms called equality, equity, and then empowerment, where people they don't even sense a sense of barrier. So they don't require any help from anybody, right? But in the real world, it won't be possible for everything to be like that. This is another way of depicting it. I really like this one. that, the first one is inequality. Let somebody else describe it. What do you see? Yeah. Anybody, whatever you're seeing.
In first, I mean, in inequality, the two people there doesn't have the equal opportunity to get the fruit.
Mm-hmm.
In second, I mean, equality, both of them provide the same ladder. I mean, irrespective of their height. So one can access the fruit, the second one cannot.
So in the first one, both had to wait for the fruit to drop. In the second one, both could reach up and pluck the fruit also, but the right one still doesn't have enough fruit to pluck on his side, right?
Yeah. Then in third one, equity, both of them were provided by the ladder according to their height. So both of them can get the fruit. In justice, they have fixed the system actually.
So do you notice the difference between equity and justice? Can you see anybody here? I mean,
So justice is all about giving the fair share to both. Like if we see equity, we have like one has more fruit towards him or her, and to the next one has no. But in justice, we see it's almost equally distributed. So the excess is equal to both.
So they've turned the system, they turned the tree in such a manner that the fruit are available even to the person on the right. Right? Understood this? Yeah. If you can see, there are poles which have been pushed up, which are propping up the branches on that side so that the left and right both can access a similar amount of fruit.
Yeah.
Is that understood? Mm-hmm. So bringing real justice is about changing the entire system, not just giving positive discrimination, but going to the root of it and then changing it. Right? Yeah, you want to say something, please.
Like in equity one also we can see that the second ladder is a bit taller than the first.
Yeah, but yet it's not enough.
Yeah, it's not enough, but still they are trying to make the second person also.
Right, correct. Yeah.
Meet that level.
Yeah. Okay. I love this cartoon. And that's why I put this. This is really the irony of it. When we have competence-based systems, we know in education also that everybody doesn't learn the same way. Some people will learn incrementally. Some people will not learn until the whole picture is available to them. And yet we had this system of, failing in the first standard, failing in the second standard and third standard and fourth standard. So the right to education in India brought in a system by which you could not fail till the 8th standard. Right? Because they used to say that children don't fail, teachers and parents and society fails. So let's put the onus on them rather than, make people feel that they've failed. It's because the system was made like equal for everybody. So somebody who was science and maths based, who was good at science and maths, was topping the class. But people who were with artistic talent or maybe even, sports or something would fail. And then you see them as condemnable people. Later on in life, it's so tough for them to actually adjust back to society. So this is typically what's wrong with a very competence-based, equal, standardized system that we have. But at least at one time, the government of India had said that we won't fail anybody till the 8th standard. Has been taken aback now. We are now again, detention has started, right? But that was because they didn't run the system well, right? Is that clear to everybody? The same thing happens in health. If we try and say that, okay, we'll give 4 tablets to everybody, that's it. But somebody, like for example, the TB patient that we were talking about earlier, he'll probably require food to go along. The person who is anyway poor, and when he or she got TB, now, his lungs are compromised, can't work on a cycle rickshaw, or maybe can't, run the thela that he was, a push cart that he was working on. Now can't earn for his family. Because he's coughing away, he's given the bacteria to his or her daughter or son or child or his wife. And now, because they can't eat enough, because the main earning member is not earning, they fall prey to TB more than anybody else. So they're in double jeopardy. So what we are talking about in typical healthcare is that medicines are not enough. Like we saw from the first graph that we had seen on TB, to this, that some people might be requiring medicine, some people will be requiring free medicine, and some people will be actually requiring medicine plus a job or medicine plus food, right? So we need to think about it. It doesn't matter whether it comes from the Food and Civil Services, Civil Supplies Department, because all departments combined, like we said about education or thing, we have to look for solutions for different people in a different manner. It just doesn't mean that only the food and civil supplies will require. For me, NREGA, the National Rural Employment Guarantee Act, was a very good way to prevent tuberculosis, because it was ensure that at least some time of this thing I can get food whenever I want. I'll leave this. We've already dealt with this. So just separating this out again, if you've understood what I was trying to say, just trying to say it in a few sentences, that equity means fairness and justice in the distributions of benefits and power. Also resources, responsibilities to reach a goal of equality for all people. So the idealist will say, I mean, have you ever seen equality, 100% equality? Yes, it's never there, but it's an ideal towards which we are working, right? That people were, they're born more or less the same with 2 eyes, 2 legs, 2 this thing. And so why should systems be discriminatory against some? So let there not be any discriminations based on gender or disability or caste and religion and all. And so it recognizes that people have different needs, and their access and control over resources is not the same. And hence we'll have to make that much of a difference. When we study, I mean, we go to hospitals, for example. If you go to a district hospital and you look at the people who are admitted there, you will find almost 2:1 ratio of men is to women being admitted, right? If you look at it in a state hospital, it will be 3:1 males to females. I'm not taking let's not talk about the labor ward, not the maternity ward or the labor ward. Everywhere else you will find this is the thing. It's not because men are falling more ill compared to women, but it is because the access or the worth of women to be saved is lesser than that of males. But more we try and go closer to the community, if we build hospitals, because of transport issues, because of the women's status and family, whatever, we see that it starts coming to 1:1 equality. The closer the hospital is to the community, right? So it very clearly means that we need to look at things differently. Whether it's the transport issue of the step ladder to get into a bus. It's so discriminatory for a woman wearing a sari or a traditional cloth, because she can't even lift the leg so high. So that itself provides an access difficulty to people to go to a city to get healthcare, right? Just that. Besides the other factors, that whether she'll be seen there or not, by the time she reaches the hospital, there might be just one bus reaching a hospital, and then by the time she reaches there, the doctor might have gone out. So all those from access issues also. So that's why the divide between rural and this thing is not based just on that your chances of becoming ill. It's also about how you manage to get healthcare, access to healthcare. Just thinking that we'll be equal to everybody actually creates inequity in health. I've just tried to write by having a health promotion material only in a single language. Maybe our way of saying that we are equal for everybody, but actually it creates an inequity for anybody who reads it, or who cannot understand what is written. And they will reach a higher status of health compared to others. And if we really believe in sabka saath, sabka vikas kind of a thing, that, everybody should move, the Antyodaya formula in India, that, we need to take the lowest person along with us, then we really need to bother about equity. Unless we achieve equality through positive discrimination and, laws which are enabling, policies which are enabling the lowest, and we know that, the woman in almost every caste or every creed falls the lowest, invariably. So just seeing that whatever we are doing is accessible, available to those who actually get discriminated against, right? Yeah, so let's what we'll do is now we'll play a small game also, which will, I think, bring out things clearer to us. What social hierarchy can mean. And we often see health inequities as something which can be done away with. It's unnecessary. And it gives a sense of despondence. If not just with yourself, I mean, people, all of us, when we are, say, walking down on a street and you find somebody hit with an accident, if I knew that there was a good, fair system, I can take them to hospital and do my duty to save a human being, I'll do that. But half the time you feel that this person will fall on you now. If I take him to hospital, they'll say, where's the money? So public health systems provide that sense of that you don't have a sense of guilt in taking and helping somebody, right? So a good public health system where everybody gets the same treatment equally, free, and which is accessible to everybody, is always a doable thing. And it's unnecessary to think of only a paid system or an insurance based system where my treatment is based on the capacity to pay, right? Let's have this. Inakshi will help us do this, right? So we'll have what have people ever done a privilege walk or a power walk? You done it? Okay, great. So those who have done it may, those who haven't done it may still learn from it. And and what we'll do is we'll have a point to take over, Inakshi.
Maybe we can bring up this, and the ones who are on the online platform can also join in. And the ones who are physically here, we will do it physically. Yeah. So can we stop screen share? Can we know how many are there online?
Almost 30.
Almost 30. Okay.
Oh, great.
So what we would do is we will take
Are you on the sound?
a few. Okay. There are a few chits here which we will go around, and you pick up a chit, and
Those who are here.
Yeah, those who are here in the hall. The chit has one
Identity
that you need to live that character for this next few minutes. For the online ones, I will display the characters, and if you all can just pick one character at a time, so we can go serially in terms of the names that are there, and we give them one character. So
it's like a role play where we assume that person, an average of that kind of identity that we know of or we can think of, and then we'll shoot some questions, and people have to move from there depending on their identity. Can we leave our mics on for some time so that, they pick up whatever is going on here? Everybody's mics can be on this side, at least on the right side.
You can take it. Done, sir. Thank you.
Hello, is the screen visible to everyone?
Yes, I can see it.
Yeah, so each of you could like pick up one character, like can we allocate it? Show me the participants. So I'll be allocating it so it will be easier. So Faizan can be 9.
I can't see the options now. I can see my picture only. Like.
Yeah, so just take a note of it. I'll show you the screen later. So
No,
you just you will be the 9th character. Then is Muniba. Muniba, can you hear me?
What is the 9th character?
Yes, ma'am. Yes, ma'am. I am listening.
Character will just show you. For now, just note down the numbers.
Okay.
So Muhammad will be 9. Muniba will be 10. Harsha, can you hear me?
Yes, ma'am.
Okay, so you will be 11th, okay? And then Safarina, can you hear me?
Yeah, I can.
So you will be 12th, okay?
12.
And Hector, if you could hear me, you will be 13.
Okay.
Then
Thank you.
Saramitam would be 14.
Okay, ma'am.
James will be 15.
Yes, ma'am.
Zainab will be 16. Zainab, can you hear me? Zainab? Okay, Govinda will be 17. Govinda, can you hear me? Govinda? Vinita, can you hear me? Vinita, can you hear me?
Okay.
Vinita, can you hear me? Okay, Dennis, can you hear me?
Yes.
So you will be 18th character, okay?
Okay.
Now I'll show you the word file. Please take a note of the character that you guys are. So the numbers that I have allocated to you, please note down the characters that you have been assigned. Everyone's got their characters? And Zainab and Govinda, if you could respond, it would be easier for us to know if you are like able to hear us. Okay. Okay, let's go ahead. So I'll request everyone to stand up and stand in a queue this side.
All those who got a chits.
All those who have taken a chit. And then we will start.
Yeah, people here, I can switch it on for on these sides so that they'll pick up whatever is going on. Okay, you want to? Okay, then you don't say.
We need to stop. If everyone doesn't, we'll look towards that side and make a queue. If everyone doesn't fit in that side, we can also come this side. Stand in a straight line.
in a way that you can move, so just leave this state.
In a way we can move forward.
Oh, Yeah. okay. So,
Like this.
it's okay.
You'll have to move that.
Straight line, like straight line. Okay, okay. Yeah.
We can do like this. We have more space. We have to move
Forward. We have to move forward. That's it. Please don't stand on the table. Stand on the two sides so that you can move ahead. Yeah. Okay. I will request. I will be making a statement. Be in your character, the character that you have been allotted. And in that character, you make a decision of whether you can take a step forward, if you can do that activity or not. So whichever statement I will read out, if you think you can act on that statement, take a step forward. If you cannot act, please stay where you are. Yeah? And keep counting the number of steps that you are taking.
So those who are online will at least note somewhere how many steps they could take forward, right? Okay.
Those online will do the same thing of keeping account of the steps that they have been able to take. So those online will also listen to the statement and think whether they can take a step forward in that particular situation. If they think that they can act and take a step forward, they will count and write that on a sheet and keep counting how many steps they could move forward. Am I clear for the people online?
Yes.
Yes.
Okay. Yeah. So please keep a pen and a pencil and keep noting how many steps you could take forward. And I'll request the same for people here.
Reminding them that this is the role that you will have. The identity.
Based on the identity that you have been given. Yeah, the character, please stay in the character. Don't go out of the character and be yourself. So please do the acting well. Okay, we'll start. I will start reading out the statements. And if you think you can act in that particular character can act, please move forward. We'll start. The first statement is, while growing up, my mother always had help at home to look after me. While growing up, my mother always had a help at home to look after me. If you think your character would have that privilege, take a step forward. Second statement, I rarely fall ill. If you think you are a part, your character would have said this, take a step forward. I rarely fall ill.
Sorry, hello. Yeah.
Yeah.
Yeah. Just wanting to. We have to keep the this identity in mind, like being a factory owner. Say, for example, I am a factory owner. So is it like
Yes.
whatever I have been going through, like while is it for me or just I have to think about the
No,
as
the
a
character, a factory owner.
This is a role play.
Yeah.
You have to take on the character which has been given to you. The
एक
identity.
फैक्ट्री ओनर कैसा सोचेगा वो सिचुएशन में?
Whatever your idea of an average factory owner will be.
Okay.
Right? Or whatever identity you have.
Okay, sure.
The third statement is, if I get injured, my mother will immediately take me to a doctor. Number 4, I can access important national and local news regularly. Number 4, I can access important national and local news regularly. Number 5, I have access to medical insurance that can take care of a road accident or cancer also. Number 5 was, I have access to a medical insurance that can take care of a road accident or cancer also. Number 6, I have access to microcredit, small loans during emergencies. Number 6, I have access to microcredit, small loans during emergencies. Number 7. I can negotiate condom use with my partner. Number 7. I can negotiate condom use with my partner. Number 8. I went to secondary school, or I will go to secondary school.
Please don't share your identities.
8. I went to secondary school, or I will go to secondary school. Number 9. I can pay for treatment at a private hospital if necessary. Number 9. I can pay for treatment at a private hospital if necessary. Number 10. I eat at least 2 full meals a day. I eat at least 2 full meals a day. Number 11.
meat?
2 full
Meal,
meals.
meal.
मील खाना 2 टाइम का
हाँ,
खाना मुझे मिलता है
उसके आगे मैडम आई ईट एटलीस्ट 2 full meat
a
In
day.
a day.
एक दिन में
अच्छा 1 day.
in a day.
Okay.
Next 11. I can drink healthy drinking water and breathe clean air most of the day. I can drink healthy drinking water and breathe clean air most of the day. Number 12. I am not in a danger of sexual harassment or abuse. I am not in any danger of sexual harassment or abuse. Number 13. I have 2 daughters. I can decide alone if I need sterilization. I have 2 daughters and I can decide alone if I need sterilization.
Sterilization, we all understand. Right.
Number 14. I can go with my family for vacation to my ancestral home or a tourist destination every year or alternate years. Number 14. I can go with my family for a vacation to my ancestral home or a tourist destination every year or other year. Number 15. Floods washed away my home. I can rebuild it. Number 15. Floods washed away my home. I can rebuild it. Number 16. During COVID, my financial status was not affected. During COVID, my financial situation was not affected. 17. My next promotion would mean sometimes going out at night at unpredictable hours. I can easily accept the promotion. My next promotion would mean sometimes going out at night at unpredictable hours. I can easily accept my promotion. Number 18. I never had to share a towel or a bed linen with a guest. Number 18. I never had to share a towel or a bed linen with a guest. Number 19. A crowd is beating a minority man. I can stop them. Number 19. A crowd is beating a minority man. I can stop them. Number 20. I can influence decisions made at the block PHC or district hospital. Number 20. I can influence decisions made at block PHC or district hospital. Okay. Thank you. Please stand where you are. And those online also, please take note of the number of steps that you have been able to take. Okay. So here we were 1, 2, 3, 4, 5, 6, 7 people, of which 4 are almost at the starting line, and the others have come forward at different positions. I will request the people here to share their character as to what their characters are, and the ones in front to share what. Yeah.
How did you feel?
How are you feeling?
When you look back, there are so many people behind you. How do you feel?
I personally feel that never look that 2% are above us, but you should be satisfied with the life you score and be happy with it.
Okay, so you were happy with whatever progress you could make. Sometimes you could not, but sometimes you could.
Yeah, but I am
Satisfied. Even when you look back and okay. What about you?
Yeah, I feel that the playing field is not leveled equally. So there will always people who would be behind in terms of privilege. And even if I'm pretty sure many of them are not minority in terms of age, which my character was like a primary school boy, 12. But even if some characters were adults, still they're not privileged enough to make certain decisions or have that means to.
Do you feel bad about it? Guilty?
Yeah.
A bit.
Yes.
Yeah.
Yeah.
Yeah, so what I think is that gender always plays a role. Like my it was returned migrant a 55-year-old man. Like there were some things that only a man can do that the society believes, and a woman or a female character cannot make decisions on that. So I guess that's that could be improved.
I also feel, suppose my character was a primary school boy, but maybe it could have been a primary school girl, then maybe I would have been a bit behind.
Yeah. Right. So, I mean, you already brought up, you would have asked this question. What about people who are who didn't move at all? Is there anybody who didn't move even a single step?
I took a step in.
Anybody who didn't move a single step? Jerome, did you take a step?
I didn't move because my thinking was that this was going to be read. Then by reading this, it allowed you to move. But I was trying to do a comparison from the reading, but I could not find anything like reading this.
Okay.
So
What was your character?
the character is an old mother's mother.
Unwed mother, age 16, a child. So you can hardly move because as an unwed 16-year-old, you are feeling so lost that none of these statements really resonated with you and you could not move.
I only say, but I could not find anything in keeping with that.
So the online people heard that. I mean, he had a character of being unwed 16-year-old mother, and because of that, felt that he couldn't move even a single step. Who moved just one step?
I took a step, but that was also in optimism. I am an orphan girl, 12-year-old, a primary school girl.
Where did you move?
I moved when it was said that I would be going to secondary school. So I thought that probably, with the fingers crossed, that I would hopefully see the school, secondary school.
Ashawadi. So, okay, optimism, at least one step forward. Right? Some others would argue that, I think an orphan girl in India.
Yeah.
Right, you're right.
People?
Pragmatism. Certainly.
Yeah, just a minute, just try.
I've come to the office, brother.
Yeah.
Yeah, so for me, she was an Anganwadi worker from Dalit community. So we know the privileges and the not privileges that Dalit community have. So I just moved, and that also out of optimism, as he said, secondary school, when it was mentioned, I thought maybe Anganwadi worker might have, like, she might be aware where to go or not. That's why out of optimism I moved. Others I could not resonate. I don't think easier. We don't have so many opportunities for someone from Anganwadi worker from Dalit community. I don't think so.
I moved twice. I'm a grandmother taking care of orphans. I moved when the microcredit question came in and also eating twice a day. But I think if I had located the grandmother in a well-to-do family, I could have moved home. But I kind of located it somewhere in middle level, so I moved twice.
That's fair. I mean, the average person is not the richest, so yeah.
Yes.
So we have all to look at. Let's hear something from the online people. I mean, who moved the maximum? What's the maximum that somebody moved? How many steps?
18 steps. Factory owner. So I'm the privileged one here.
So factory owner, you traveled. What was all the thing?
So 18 steps. So I moved 18 steps. So one step was like I think I would have only stepped 17 times, but one step I moved like I thought like let me show that factory owner to be an empathetic and humanistic one. So
okay.
So yeah. So I was the privileged one, so I felt everything, all the statements. I can do that. So yeah, except two statements. What one was about the promotion, and another was the financial status during COVID. So at that time, I felt like they might have got some pinch at that time. And statement 19 was about beating minorities. So first I thought like I'll not stop at there, but like let me be a bit of humanistic or empathy in me. So I tried to put it yes there. So that's 18 steps for me. Yeah.
Okay, I think you're lucky that you're not here. Otherwise, you would have to break the wall. 18 steps. Right. Out of 20. Great. Anybody else? Somebody who didn't move at all? Or move just one step or two steps? Amongst the online people. Hello. Anybody online who could move only one or two steps?
No.
Okay, who's the lowest then? Anybody with 4 or 5? Anybody who would like to speak about what the experience was while listening to all this?
Sir, my number was 14, district education officer.
Yeah. So how many steps did you move? Let's hear.
I moved 18. I moved even me also I moved 18. But I was thinking if the officer was a female, then the number would have decreased. Since it was a male,
No, we didn't say, but anyway, you presume that it would be a male because most of the director educations would be male, right? So it's okay. That's fine.
But if it was a woman, a female, then she would have not been able to move that much of steps.
So do you remember which ones do you think you may not have moved if you were a woman?
Let's say that related with stopping a minority being beaten up. Let's say that one was that one, and then another one was regarding sterilization.
Condom
there
use.
were one.
Condom use with, sharing with partner, to use a condom.
That one I take as a male, I take it movable.
If you were a woman, yes.
There was another question where I already had two female child, and then whether I can take the decision on sterilization. There was another question.
And you thought you couldn't take it if you were a woman?
To my understanding, I thought it might be a little hard.
Okay. Well, fine. I mean, this is all about our experiences, and that's the reason is to talk about it rather than just give it as a question answer which is right and wrong. It's about our lived experiences that we've seen in life, heard about it, or read about them in papers. Yeah, so that's fine. Anyway, so anybody else wants to share something?
Yes, sir. This is Hector.
Yeah.
Okay, so my number was number 13. So I was able to move 2 times. that is visually impaired young man from a rich family. So because of the condition, I could not move around myself. Somebody have to help me. So one of the questions was question number 1. I said my mother always helped me move around. So I was able to move around like 2 times, 2 steps.
Okay, yeah. So we were looking initially. Okay, so that's what I knew there would be some people who didn't move more than once or twice. So you were one of them. How did you feel? Did you feel bad about yourself? Did you just feel that the world was unjust to you, or what was the feeling?
Yeah, there was this feeling that why I say that all I'm moving ahead and I can't help myself. I need to look for somebody to help me to move ahead. So I didn't feel good about it.
Yep. Okay. Those who hadn't ever done a power walk, how do you feel? How did you like the game or whatever?
It was great. I liked it really. So yeah, it's the first time I'm doing this. So, but it was good, enjoyable. So also like thinking about the things, taking somebody else's, thinking about somebody else and then trying to see how, they might be doing or they might be thinking, what their thought process is, when you go through that. So it was good for me. Like I enjoyed it really. Yeah.
Thanks, Fagan. This is often called not just a power walk. Sometimes it's a privilege walk. We change the questions accordingly and try to see. Practically here also, I mean, all the characters that we showed was something that we could not have done anything about it practically, right? This you got it as a saugat from your parents or from the society, and you couldn't do anything about it. So the world looks very biased and unjust. And looking at equity is that it's about how do you provide certain amount of hope and some relief so that people can cross the boundaries which society has put or the institutions have put by virtue of rules, regulations, all that. Yeah. Yeah. Right. And I am a big votary of it. I would request almost everybody, if you understand this and can conjure up something and do it in your offices, I've had people weeping in these sessions sometimes because it mirrors their life journey sometimes. The chit that they got or somebody whom they knew very closely. And it just revives that. And, things like you're born in a family like that, or your father came as an immigrant somewhere and, you were left to, you couldn't, because you were an immigrant. I mean, you could not even get educated because you can't get an Aadhaar card or something and you can't do education. So you ended up becoming only a rickshaw puller and then your life is stuck. Right. So there are no ways to cross that. And so constantly as good administrators, as public health people, as, wherever we are, and I said public health is not about only education or health department. So wherever we are, how do we create rules which facilitate people to move up rather than, keep making rules and regulations which actually hinder people's health? So that's the job. And that's why we are discussing this. And Akshi, you want to say something?
Yeah, and also sometimes we see I think the power walk always gives you two elements of the same thing. One is that, okay, the deprivation comes out. You don't even think in those terms sometimes, but then doing this exercise, you always feel that because it's an experiential. You get into that character and you start feeling that, whether it's the loss or the privilege, either ways. The other thing is also sometimes you start suddenly realizing, like someone I really liked who said, going ahead was easy, but then the thing of sterilization or using the condom, how easy it is to negotiate even for a privileged person, perhaps. An educated lady might face the same level of challenge as would be an illiterate village woman to be able to negotiate with the partner on certain issues. So I think,
or face the prospect of sexual abuse being on the street or being at night alone.
so some of the things are again there are so many dimensions of discrimination or deprivation that exist that such exercises make you realize that it's not a single dimension की Dalits से है इसीलिए it elevates, but there is issues across board.
Yeah, can we have the PPT again, if possible? Yeah, we'll move to the PPT again, and if you can't see it, please let us know immediately.
Yes, it's visible.
Yeah. You can see now. Yeah, thanks. So, it'll never be an equal world. We definitely understand it'll never be an equal world. But I mean, once we ingrain this concept of equity and knowing that inequity will breed violence in the end, it will waste a lot of money. I think it should be an endeavor for everywhere, wherever we are in the administrative system or this thing, to try and reduce the inequity so that everybody feels a sense of equality. It's about that, because once a person feels that the whole world is loaded against him, he or she loses hope. There's a very interesting study. I think it came out in 2005 in UP. It's a World Bank study done in UP. And what they did was they took one boy or girl from different villages who didn't know each other, and they brought them together and gave them a kind of a test which had a bit of cognition and bit of deciphering, which was appropriate for their age group. There were psychologists involved in testing them. And when they did this test, nobody knew each other. And when they analyzed the results the first time, they did this test, gave it to everybody. They noted down the results. And then they asked everybody to talk about their name and which village they are from and which caste they are from. Sometimes the names itself divulge the caste, but sometimes they don't. So they told them to talk about their caste. And then they gave a test of similar difficulty, which they had given earlier, slightly different because they're not practiced on it, right? So they gave them again. And when they did that, they found that the scores of those who were from Dalit communities or OBCs, it dropped immediately. They didn't do anything else. They didn't change their caste. They didn't do anything else. Just the knowledge that who is who made probably a sense of that the sense that the whole system is loaded against me, that I won't be able to cross this barrier. When they didn't know, they crossed. In fact, the scores when they did the first time were maybe statistically insignificant, but slightly better than the lower caste had a slightly better score than the upper castes. But the moment it was decided who is the upper caste and who is the lower caste, it seems the upper caste started doing better because they felt more confident, and the lower caste dropped. It's a very, very interesting study done by Indian people, but it's a World Bank funded study which was done in UP. So again, and for me in the Northeast, where people just from your eyes or from your nose or from just your facial features, you can make out the person is a scheduled tribe, is from a scheduled tribe. What must be going on in their minds? You can't even hide this. You can't even go to the first part of the study. I was wondering whether we can do that study at all or not, because here your face reveals your caste sometime, or your. So these are very important issues which we have to constantly deal with. Just believing that whatever we are doing equally is not a very good way of looking at administration or your own job. It's just basically we are talking about that. And as I said, the more we can, there's been a commission on social determinants of health, and they see that as an ethical imperative by every department, every country, every state, wherever you are in. you have to put right these inequities. They believe that all these differences in health are coming out from something which is remediable, that it's a matter of social justice, right? And they actually went ahead and said, this WHO Commission on the Social Determinants of Health actually used this word, that social injustice is killing people on a grand scale. It's almost like an epidemic. We are not talking about it because we don't have data also which is differentiated on all these things. At best, we have gender. Rest is not there. So we need to keep identifying inequity from time to time and see that our structures, norm, institutions are, something which enables people, which enables the people who are discriminated against to do better in life, right? And so it's very important also that where we do set up systems, we must have systems by which we can disaggregate the data, in terms of caste, creed, religion, all these factors that we talked about, right? So that we can provide better systems to them. So it's very interesting to say that, individually we are different, probably biologically, we have a bit different genetic makeup, or, we might have, but the society's pathology weighs much more on us when we have to look at disease and how we get rid of that. It's not a natural phenomenon. It's a result, as they said again, it's a result of a toxic combination of poor social policies, unfair economic arrangements, and what we would call bad politics. So we need to have systems which are uncovering this from on. As I said, I'm not one who's trying to say that, reservations or whatever have to be. It's a job to keep looking at what is keeping people away from good health and keep studying it. And then, for example, I went to one of these a very rich private eye care facility. Now, it was so funny that most people, would come for eye care would be, I would say, adults and, old people whose eyesights have got spoiled, whose retina has got spoiled or whatever. All their chairs are so short that people find it so difficult unless somebody else is helping them to rise. So it doesn't even cross our minds that we are creating a disability where they shouldn't have been. You call in people for disability of the eyes, but you have to also be careful about the disability which happens along with that when our eyes are spoiled. Most of them will not be able to get up from such a low height of chairs. So that's what I'm saying. So sometimes our systems are creating disabilities where we should be mindful of what we are doing. So I just wanted to introduce this term called intersectionality, right? And I think that's where we'll end with. It's not a very difficult concept. We've already talked about. So here we have tried to bring this out. There are various types of social factors which can discriminate, which can oppress others, and we need to be aware of them. We can never do away 100% with them. But if you're not aware as an administrator, as a participant in governing that system, so sometimes it's about the sexuality or the gender, disability, nationality, racial identity, rural or urban, educated and non-educated, and sometimes they go together. A rural person doesn't get good schools, so remains uneducated most of the time. Right? A person who doesn't have money can't go to a private education, hence remains uneducated, and then gets into a vicious cycle of lack of education and poverty. Can't come out of it. So look at these kinds of things. There's so many things which are going on which can affect it. Now, it may not be possible to remove everything, but we need to be aware. Looking at that data, for example, of, when we were showing the data of, infant mortality or something, you'd be surprised that we are now started keeping data that, the child mortality, when the children are already, they've got 3 or 4 children already, the child mortality seems to be much higher. You would think that they have already known how to look after their children, So after 3 or 4 children, no child would die. But no, it makes a difference to the child mortality. If there are more children, more children die in that family. Right? Similarly, it's about fertility. Right? So we don't think about it, but it's there. And how we can, of all these things, these have come out from qualitative studies. Unfortunately, doing this from only quantitative studies doesn't happen. If you talk to more people and talk to people from a diversity, diverse kind of background, you get all these kinds of things, and then you realize what all challenges people face to access healthcare. Simple thing about abortion, for example. I spoke with a whole lot of A&Ms, nurses, and when I asked them that, is abortion legal? 70% of them said it's illegal. These are nurses who are supposed to be providing abortion services or medical termination of pregnancy services. In India, there's been an act since 1975. I think Mrs. Gandhi brought this in, or 72. I don't remember. Somewhere around that time, when it almost as a right that, except in certain circumstances, women will have a right to get their pregnancy terminated medically. But most A&Ms to date feel that it's a... And if it comes to an unwed mother, the whole society feels that, instead of somebody who needs help, you tend to start discriminating against her. Right? So it's... Kimberly Crenshaw was the first one who actually talked about intersectionality, brought this term into practice everywhere. So what basically it means is that, different social factors, the backgrounds, they not only just interplay, but sometimes compound the discrimination or the oppression. So we need to... So for example, I would say an immigrant citizenship. I mean, if you see this picture on the right side, an immigrant of a minority religion who is a woman and probably is gay or this thing, a lesbian, will have 4 different kinds of discrimination mounted on top of her. Right? And if she was a disabled, then further. So it's not just solving one challenge, but being aware of it and, bringing that into all the systems, all our health systems or any other, even an office I was talking about. If health is a big thing that we think of, is mental well-being or social well-being or this thing, we need to know about that intersectionality affects people, and affect the more the discriminating factors, social factors, the worse it gets for people. This is maybe a tough diagram, but we'll share the slide with you. This is from the Commission on Social Determinants of Health, and they talk about how, on the left side, if you see, very often the socioeconomic and political context is driving the socioeconomic position. It's not just, who remained. I see it very often in the tribes in the Northeast that, who are very equality-oriented, equity-oriented communities. Then education came in, and those who were educated managed to get a job. So whereas in tribal life, where there were always, vagaries of life and nature were there, and they were, in 1 or 2 generations, they would be poor, and then the 3rd generation, they will be very rich. Or somebody who was rich after 2 generations fell down because there weren't enough people in the house to help, or somebody died of maybe a fire or and the whole family's economy went down. But at some point of time, if one generation got educated and got into a permanent job, they kept moving up because they had a definite source of income now. And so suddenly a tribal society, which was very justice oriented and equality oriented, today has got a class barrier now. Right? That's because we made policies in which only the educated with a government degree or with a proper education degree could get a job. One could argue that people do not get educated only with a government or with a government certified this thing, right? People could be smart despite the education, but then we made that as a very important part. And so people who get educated keep moving up. right? And once you allow, so again, in many of my Naga areas, for example, you still don't have private property. The village headman is supposed to be the repository of the land, and you get the land that you want and you can use. If your next generation cannot use that thing, the land goes back to the village, right? But now, once you move up and you can buy property in the cities or some other place, you allow that your next 5 generations also will never get poor, because you have a right to property, right? So very few people know that Section 370, which we all talk about in Kashmir, came because they wanted it, because they felt that India's seventh, at that time we had 7 rights, fundamental rights, and we had right to property as a right which went away only in the 70s. So they felt that if right to property was allowed, they will not be able to look after the majority of their people, because at that time around 30% of the population had 70% of the land. And they had a land to the tiller movement, one of the most successful transfers of land without any bloodshed. But we don't even talk about it today. We just feel that Section 370 was one of the reasons why they asked for it, was because of this whole land issue. At that time, around independence, 70% of the land was only with 25-30% people in Kashmir. And they challenged that for this reason. Because once you have in many Western countries also, some states in the US also, you cannot get automatic land from your father. You get the first right to buy that property, but that's about it. Right? Because it's considered to be state or God or nature's thing to you. This sense of property which has come maintains the disparity once it comes in. Right? So there are many people who have talked against it. So in one sense, we think that that's the given, but it's actually a social and a public policy which has allowed it, that some people who move up then move up for 5 generations, 10 generations together. Right? So it finally has an impact on equity and health and well-being, any of these things, because all of this, the social class that you are in, the kind of caste that you are in, the kind of social categories that you can enter in, will finally, determine whether you got good medical care or not, whether you got a good job which gives you a certain amount of leisure time or not, right? So all this is. So they were talking about. So that's one of the reasons why SDG came in, because of this Commission on Social Determinants of Health, which said that we need to try and close this gap within 1 generation. They're saying, right? And it started from which I talked about earlier, from that Whitehall study, when Michael Marmot pushing this through in many places. Person, totally a doctor, a health person, but looking at health from a very wide perspective of determinants of health. Right. So these are the key takeaways from this session. What's the time like? 3:57. Oh, wow. Okay. So it's around 4. We'll just have discussion after that. So we often slip into this, that we can't do away with inequity. वो तो होगा ही. ऊंच नीच तो भगवान ने बनाई है. Right? Which others might argue कि, this is not this thing. They probably God did not make caste, or they created, yes, 2 separate biological factors of gender. No, sorry, sex, not gender, right? But then we have entrenched it in a gender classification and the roles that people play, and we'll learn more about it tomorrow, right? Which is maintaining an imbalance in society. We need to go beyond what is immediately visible and try and look at the conceptual understanding of these discriminations and go against it. Very often we have tried to make modern life itself is all about individualism. They want to make you individual so that you can make a choice quickly to access the market. The whole education system is made like this. The whole market system is like that, right? Because you might not have cash today, so an advertisement will not work on you. So you make a system by which you can pay by a card. You can pay by credit also, even if you don't have money. And then you have a UPI system where you don't have to consult anybody. If you wanted to go to the bank earlier, people will say, where are you going? I'm going to the bank. Why do you need money? I need because to buy it. So somebody or the other in the family would say, yeah, why do you need that? I got one spare. Why do? I'm not using my own thing. Why don't you take it? Today now, the market is at my access. So it's creating that individualism. And because of that, we tend to blame the individual also for the choices that person is making. So let's look at, things from social structures and institutions. Let's look at what are the norms and values which need to change to bring more equity. And can we do something against? And that's why we all talk about. I was doing a session on, a few days sessions to all the TB officers in the government of India on gender. And it was so funny that there's one person, or quite a few people actually, and I was doing for the eastern region. They said this is a Western concept. हमारे यहाँ कोई gender की problem नहीं है. And the irony was not lost on them. Of all the officers which had come from the northeast 7 states and Bengal, only Bengal had sent 2 women. Rest all were men. Right? And they said gender is not a discriminating factor in our place. So the idea is that we get blinded, and we tend to blame the person for the thing, and that we are okay. But this inequity is maintained by the social hierarchies, the kind of relationships that we have. I worked for a short while with the government and in a political space in one sense, and all our meetings were starting at about 10 at night, continuing till 1 o'clock. Now, any woman with a child will not be able to participate in those discussions. And it was lost on them. They said, we've provided an equal thing when women should also dare and come at night. But they have social responsibilities. How will they do it? And so, some things which women probably would understand was not coming into the discussions on which we were taking decisions on. So again, we need to keep ourselves abreast of this, that, in a less than equal world, we need to think deeply. It's not a static. It's not a given. It's not something which nature has wanted. Right? So there's some things like what we talk about structural violence. There's stuff about structural poverty, right? How people are kept to be poor because of a system, right? I mentioned it a bit earlier. And then, about exclusion and suffering. So how do we do better than what we are doing? That's all. I'm just ending it here. Let's have our tea. I think others also, 10-15 minutes, we can take a break, have tea or coffee or whatever at home, and then we'll get back here, right, to discuss. And I would like to hear your comments also. Shall we start again?
Is everyone able to hear us?
Yes.
Yeah, we can hear you.
Okay. So we'll start this session, but before that, we would want to felicitate our speakers who had traveled so far from Northeast, and our dean would be doing that, our dean, Professor Dipanshu Mohan. So let's begin.
Would you like to share the picture then? Wow.
This is of many scarves that
Yeah,
coming in, but
collecting.
this is a good weather
Yeah.
to share this.
Right.
So as everybody would
I
know.
should make
Thank
a collection
you.
of
Thank
this.
you. Yes, please, please.
Thank you.
So we have also some information that you've been collecting about the office. There is a new report. So this is pen and mark. So this that
Thank
you will
you so
share.
much. Thank you so much.
So I must mention about the docket that will come in. It has one recent report you must have seen the link of, which is the Solidarities Initiative,
absolutely.
the bonded labor study. A lot of time, 1 year's work has gone in. Interestingly, this organization had 15-20 years of data on bonded laborers, Mehnat Kash, and they just had the data. They could not find the resources to put it together. One of our faculty members, Preeti, worked with them, and 2 of our students were involved in cleaning the data and spending a lot of time. The report just came out. We did a press launch of this in Delhi, and we'll share that with you in the document.
That was shared with Walter. Walter used to be the Supreme Court's this thing on bonded labor at one time, and he's now in the Northeast.
Okay.
So,
thank you. Thank you.
So I shared it with
Ma'am, please. All right. So each of the colors, ma'am, represent a school in the university. So thank you so much for making the effort and coming so far from so far.
My pleasure.
Thank you, ma'am. So we'll take a collective photo.
Yeah.
Sir, if you could also join.
Yeah. All right. Thank you. And just this, ma'am, you can put it in this and
Sure.
There's a pen and a mark.
Thank you. Thank you so much.
Guys, please
yeah, we
carry
can
on.
take a photograph she wants. While
No, later
We'll
on,
do it once
you
the
after
session
the-
is over. Yeah.
We can do it while he's there. Photo of the laser while he's there.
Okay.
We can do it.
Oh, then everyone can join for the.
Whoever is willing.
Yes.
Always add this disclaimer. These
Everybody
guys,
was
come.
willing.
Those who are students.
Because
please
the
come.
autonomy thing is so big now, you know.
अरे सर क्या
नहीं मैं कह रहा हूँ कि बहुत इम्पोर्टेंट था और धीरे धीरे वो जो the whole thing about democratic dictatorship आ गई तो वो autonomy का चार्ट बजा close up yeah
Nasima, yeah, yes. Come. Is he coming in?
you can actually go into 2 layers.
Yes, everyone please.
He
Yeah.
can take a
Yeah,
picture. You
just
can
Nasima, you come in, please. It's also good. Yeah.
Yeah. She has been.
Yeah.
Last
Nasima and
night at
Saqib is
10
been-
also.
Yeah.
He was there. I was feeling so bad.
Thank you, guys. Thank you.
Sorry guys, I think you got left out in the picture.
Online.
Yeah.
Sir, I'll see you.
Yeah, basically this is a wrap-up session now. Last half an hour or whatever we have. Just wanted comments or feedback on how was the day? What did you learn? What are the takeaways that you have had today? Just a round of that. Right. Can start anywhere. Who wants to go first? You want to start from here?
So it was an insightful session, and we're really thankful that JGU and that you traveled from so far to deliver this workshop. First of all, second, I mean the takeaways. First and foremost thing that I could take away from the session was, which was really enlightening for me, was how the class or the strata from where you come from actually affects the health. Like you we discussed through the graphs and the study that was shown that people working in middle or lower segment jobs are not really healthy or die really early and have health problems. Then the other takeaways, like in the end, we discussed about intersectionality, which is really very interesting to. I would really want to delve deeper into it to understand the nuances, as it is really important to understand how a person coming from different perspectives, different social background with different, restrictions or the constraints that a person might have due to the background that one comes from, be it gender, race, caste, nationality. So all of this was really helpful in understanding how development and how public policy should be, framed in order to cater to the needs of all, and how equity should be promoted instead of equality, so that most of, or at least we should try to cater to most of the people in the society, so that they can at least step ahead from where they are right now and take a step forward.
Thank you. Yeah. Anybody else?
Yeah. Hi.
Okay, Faizan.
Yeah. Thank you very much for the session. So it was like it's been like after like 2 or 3, like more than 3 years, I have attended this for like the workshops again. So it was in the PhD I used to attend the workshops and the conferences and all. So after like 3 long years, I have attended this conference. So it was it was great. It was nice discussing about the health. So I have a background from IIPS, so I have done my MPS and MPhil from IIPS. Yeah, so I was going back to those days.
So the NFHS data is from your institution.
Yes. So it was great. So I've been working with an organization since last one and a half year. I'm not working. So I have gone back into a shell. So today I saw this opportunity, this workshop. So I thought it as an opportunity so that I can go back to my roots, go back to the academic discussions and all those. So yeah, it was refreshing. It was great, and the way the presentations and the activities were done. So it was great. It was nice. Thank you very much. Yeah. So
Thank
hopefully
you.
I'll be there for the next 2 days also, attending this thing. Yeah. Thank you very much. Yeah.
Thank you for that. Yeah. Anybody go? I mean, yeah. There's no compulsion also that you have to say, but I mean, yeah. Just so that, I mean, I also know that if some wrong messages have been passed, then I know, and what has been understood, that also, in case we can just talk about what we got from the sessions today.
Okay, I'm actually touched looking at the infant mortality, the chart that we just dealt with, the urban section and the rural section. It tells me that the health sector has some more work to do, and in order to achieve the agenda of the health in the entire sector, we need to do more publicity, more awareness, talk to policy makers in order to look at these challenges that the community or the society is challenged with. In the absence of awareness, mobilization, making sound policy, the health sector will be strongly there. So I am touched today, and I have learned another way. And the second thing is looking at the health sector alone. From the beginning, I have understood the thing to be like when they talk about, in fact, the lesson today, we need to take it from the cycle of the health, or from the health cycle, and look at the other sector of legality, other sector of the national religion. Where do we stand if we actually want to achieve our agenda? Thank you so much.
Thank you. Thank you, Jerome. You want to say something? No, you've been there since morning, so yeah.
Thank you. This was a really interactive session and some new topic to learn and get aware of. And the use of the pictures and the activity made it even more clearer.
I forgot to mention this, that, it cropped up at some time, how come in some states the infant mortality was better in the rural areas than the urban areas, right? When I'm looking at the data, they're not just Kerala, there are 3-4 more states, smaller states, tribal states, where this is there. And it's very interesting because actually, when we try, and as public health people, we try and discern what is the reason for it. And so one of the things is that as the government system, we don't have an urban health system really. We only have a rural health system. We hardly have one. So cities where there's less of equity and cities where there's more poverty, in those areas, the cities get more deprived than the rural areas, especially. So a state like Kerala, which is better governed, with better panchayati raj, so the government system reaches out much better than, the urban areas where the urban poor are staying in this. Two is some states which have very high urbanization, 40-50% urbanization. There also, the diseases are transmitted much higher in a congested area, and the rural poor who are not getting as much of services as they would need, so they tend to lose out, and so the infant mortality is more in some of these states. So just wanted to say that it's a function of two things. One, that in the city, sometimes your equity is very poor because a certain amount of class is servicing the other class, and then there is no government system to that urban health system are hardly there from government side. It's only the rich private sector is there, and so people get they become poor just accessing those health systems in the cities. So these are mainly the reasons. Yeah, just thought I'll explain that as a question which I forgot to answer. Yeah. Anybody else?
Sir, I'm Safrina here. Thank you
Yeah,
for the
Safrina.
whole session. I would like to add this Kerala scenario about this out of expenditure. Nowadays, there's a controversies going on. After this neoliberal era, the more the private hospitals are emerging. So most of the urban population is depending upon the private health sector for all this. So the out-of-pocket expenditure is getting high in Kerala.
I fully acknowledge that. I think though we talk about the Kerala model of development all over in India, domestic violence and alcoholism is also very high in Kerala. And Kerala happens to be something like an urban village. Throughout you'll find this thing, but yes, compared to other states, it doesn't have the best health system. I must say that it doesn't have the best government health system. It's probably far better in Tamil Nadu, or even Kashmir, I would say, has got a much better public health system than even Kerala. But then the determinants of health are far better there in terms of the air, the pollution, the kind of panchayati raj which makes development, other paradigms available to people. So that's far better in Kerala. And as I said, they started from a better state. The Travancore kings at one time had done very good work in the place. So it's not only the Panchayati Raj, but it's starting from a better podium in 1947. Yeah.
Okay.
Yeah,
Can
Hector.
you hear me, sir? Okay, good. I want to say thank you for the workshop today. This is my very first time. You won't believe me. This is my very first time to attend a public health workshop. All along we've been doing other
Our
things.
privilege.
Yeah. So the lecture have been really, really insightful. They have been so good for me. And one of the key takeaway I have is with the graph, starting from the reality coming down to justice. And all of the elaboration was so nice. And I got at a certain point in time, I got a bit emotional. Where you have somebody is in fact they are of the same height, but then you still use a ladder that is far in length, but you can still access the fruit. I mean, it got so emotional. So, I mean, everything was just nice today. I want to say thank you again. And I'm really blessed to be a part of the workshop today. Thank you.
Welcome. Thanks, Hector.
Yeah.
Inakshi, you want to say something? No? Yeah, whatever. Because we'll end the day a bit early, maybe. Yeah, that's okay.
Yeah, thank you. Thank you, everybody, for joining in today. And we weren't really very prepared for a hybrid model, so we had to make some adjustments while on the go. And I hope still the people online have been able to engage. And I think the way everyone has contributed throughout the day has made the learnings more enriching, even for us to hear perspectives of people is always very, very enriching. And I think that's the best part, because people here have a lot of knowledge and experience, and that conversations triggers thinking. So thank you for that. Tomorrow, particularly, we would like to take you on a journey with us to the Northeast. We can't take you in person, but we hope to be able to transport you virtually to some of our places there and share our experiences on the ground. A lot of things which we have discussed today, contextualizing to the experiences on the ground that we see coming from these things, and a few added dimensions of climate change, gender, and conflicts that is very much there in the Northeast, and how we have been working out there, and the experiences we would like to bring to this table, and also hear your reflections. So looking forward to more conversations tomorrow.
Yeah. So this module is not just about public health, but we thought about introducing the Northeast to some extent, and because people even in India, I mean, you're from Liberia, but people within India also know very little about it, or have heard only cliched things about it. What comes out in the media, and we thought that we'd do that, and hence also try and keep, because it's not that Northeast has different problems. I mean, it's just that we don't hear about them. And so through that, we are also learning about the inequitable situations, right? So it's about that. So that's why we thought that we'll bring in all the examples from the Northeast, right? And that's what makes it special. Otherwise, anybody from Delhi could have come and, taken something on public health, right? And as Sinakshi said, looking forward to tomorrow. Thank you so much for being online. It's not easy, I can imagine, to engage the attention all the time, right? And despite some of the challenges that we had. Thank you so much. Let's call it a day today. Anything else anybody wants to say? But I can't see every one of you, so that's why. Is it okay? Can we say bye today? Bye for today.
Thank you very much. Bye-bye.
Bye. Thanks so much. Okay.
Thank you, sir.
Bye.